A review by Wu Yang published in the Journal of Bone and Joint Surgery looked at the diagnosis and management of SI joint conditions. The SI joint is a joint in the low back area, and it's comprised of the sacrum and the ilium, and then in between right here is the SI joint, and it's been thought that that is a potential area that causes low back pain. There's been some debate whether this joint actually moves, and biomechanical studies of this joint have actually found that it moves and rotates about 10 degrees, and then it can translate in any direction for about 6 millimeters. And when we talk about diagnosis, sometimes we try to do like a movement evaluation of that SI joint to see if it's moving or not. However, if we really think about it, to analyze this joint, it'd be very difficult to do. For one, we have the glute muscles, which are kind of surrounding this joint, and so we'd have to feel through the glute muscles all the way down to the joint, which isn't going to be a feasible thing to do. But also, if we really think about either 6 millimeters, which isn't very far, or 10 degrees of motion, if we actually look at how much 10 degrees of range of motion is, if we go from here to about there, that's 10 degrees, and so being able to feel that subtle motion, especially through the glute muscles, just isn't feasible. Unfortunately, there's not a single exam that will confirm our diagnosis of a SI joint condition. However, we can use multiple tests to increase our specificity and sensitivity to diagnose these conditions. There's 6 main exams that we can do, and what we're looking for is to have at least 3 positives, so that way we can be confident that the SI joint is the pain generator. The 6 exams are Gainsland's test, compression, distraction, Faber's, the thigh thrust, and then also a sacral thrust. For treatments, the review discusses a couple of different approaches that are commonly used for SI joint conditions. They looked at corticosteroid injections and found that the evidence behind using these for SI joint pain is weak. They also looked at prolotherapy, and there's mixed reviews just because for prolotherapy, it hasn't been shown to be better than either corticosteroid injections or placebo, and so the effectiveness of prolotherapy appears to be unknown. They also looked at manual manipulation of the joint, and they found that there's not good evidence supporting the use of that treatment, although they did say that for a non-invasive and a non-surgical approach, it might be warranted for those who don't want surgery, although the mechanism of how this actually works isn't clear. This review seemed to focus on minimal invasive fusion, which was their recommended treatment approach for SI joint pain conditions. And they cited a couple of articles that found that minimal invasive fusion produced both statistically significant and also clinically significant outcomes compared to non-surgical approaches, which is great. Obviously, the minimal invasive fusion is providing some benefit, but when I actually looked at some of the studies that they suggested, the problem is that there seems to be, for pain, there's an initial reduction in pain, and then for function, there's an initial improvement in function 1 to 3 months after the intervention, but then it seems to plateau and it doesn't seem to get any better, and there's not complete resolution of either pain or improvement in function. And if we're going to be fusing a joint, I would expect there to be a continual improvement. It might not get completely down to 0 for pain, and it might not be fully restored in terms of function, but we'd be looking for it to have a substantial improvement, so 80, 90%, but it doesn't seem to actually get to that amount. And so to me, recommending minimally invasive fusion seems to provide good short-term results, but then it kind of stalls out. And this reminds me of some of the other studies on surgery that we have for musculoskeletal pain conditions, in that when we do these surgeries, we don't know if it's actually the surgery that's beneficial or what happens after the surgery. So it could be that there's rest after the minimally invasive surgery, and that's what's actually producing the pain relief. There could be just a placebo effect of having that surgery and having that improvement, or it could be the post-surgical rehab that's actually beneficial. I don't think it's well established with this kind of procedure for SI joint conditions, and I think that's where some research needs to be done. And on top of this, exercise wasn't included in the treatment approaches for SI joint pain conditions in this review. And I'm not sure if that's because there isn't any research on exercise for SI joint pain conditions, or if exercise just hasn't been shown to be effective for these conditions. I don't know why it wasn't included at all, but I think that it should be, especially when we kind of evaluate the research as a whole for treatment of musculoskeletal pain conditions, in that exercise seems to produce at least mild to moderate effects when we look at both pain and function. And so even if it's not an exercise program directly targeted at the SI joint, so if we're doing glute strengthening or something like that, but exercise produces some pain relieving effects, and so maybe walking is beneficial for these conditions, or running or something like that, where we're stimulating the analgesic effect of exercise. And so I think that was a big portion that was missed out in this review, and I'm not really sure why it wasn't included at all.